Hello, good afternoon. Today I'm gonna present about comprehensive nursing management of COPD exacerbation. I'm Pratima Bhandari and my student number is 2208552. Here we have the first slide, and the second slide is about A2E assessment, where Mr. Nazzle's airway is clear and patent, maintaining own despite respiratory distress. Productive cough with yellow phlegm is present with no obstruction. However, monitor cough as it may consist of mucus which may compromise the airway. The clinical decision for this would be suction may be used if any sputum production noted during cough to keep airway clear. So for circulation, Mr. Nagel is tachycardic with heart rate of 128 beats per minute, hypertensive with blood pressure of 168/85 mmHg, potentially due to hypoxia and respiratory distress, along with fever and infection, as CPR is 25 mg per liter, elevated white blood cells. Capillary refill of 3 seconds could be due to poor perfusion and possible peripheral vasoconstriction. For that, clinical decision would be to prevent complication like arrhythmia and hypertension exacerbation. Fluid balance should be managed and monitoring cardiovascular status. For exposure, febrile with no sign of external injury, hyperinflated lung can be seen in X-ray report, which is consistent with COPD exacerbation. Clinical decision for that would be infection control due to COVID-19 and managed fever. For breathing, severe hypoxia with SpO2 of 78% in room air and increased shortness of breath and respiratory rate of 30 beats per minute. Significant respiratory distress can be noted due to use of accessory muscles, wheezing and crackle sounds due to breathing indicate bronchoconstriction and mucus in airway, hypercapnia of 60 mmHg and low oxygen level 55 mmHg on atrial blood gases point to impaired gas exchange. Clinical decision for that would be use of oxygen therapy to improve oxygenation should be considered along with bronchodilators and corticosteroids to relieve bronchoconstriction. In disability, GCS is 14 out of 50 due to confused and distress, which is likely due to hypoxia and hypercapnia. Deteriorating respiratory status could cause more confusion, so neurological function should be monitored regularly. And clinical decision for that would be urgently addressing hypoxia, considering the effect of medication on his mental status. On my next slide, I have 4 nursing interventions, which includes administering controlled oxygen therapy, where as Mr. Nazzle's SpO2 is 78%, it indicates severe hypoxia, which can be managed by administering oxygen, resulting to improved tissue oxygenation and preventing further complication of hypoxia, such as confusion or cardiovascular strains. Administering bronchodilators like salbutamol and ipratropium. This medication reduce airway resistance and help relieve bronchospasm, resulting improved airflow. Bronchoconstriction is indicated as Mr. Nazzle is wheezing and using accessory muscles, which can be allopated with the help of bronchodilator. Third one would be positioning and hydration, which is important because to improve diaphragm function by reducing the work of breathing, Mr. Nazzle should be placed in upright position as he is febrile and respiratory distress, leading increased fluid loss. So IV fluid can be very essential to maintain hydration. And the last one would be administering antibiotic. Bacterial infection may be suggested by productive cough with yellow phlegm and elevated WBCs which could be treated as azithromycin, which is a microlide antibiotic that can treat underlying infection, reducing symptoms and preventing further lung damage. For the next slide, I have nursing consideration for therapies and medications. In that, the first one would be oxygen therapy. Assessment for that would be SpO2 should be regularly monitored. Administration oxygen should be delivered via nasal prone or mask depending on oxygen requirement, maintaining 88 to 92%, as higher level could suppress respiratory drive in COPD patient, where we could also consider non-invasive ventilation if hypoxia persists. Side effects for that would be if high oxygen concentration is given, there would be risk of oxygen toxicity and carbon dioxide retention. So that should be closely monitored. Second one would be salbutamol, and it's for that the assessment requires respiratory rate, breath sound, heart rate, forced expiratory volume, peak flow, central nervous system stimulation, serum potassium, serum glucose, and asthma symptom, and patients respond to the treatment should be continuously monitored. Its administration can be delivered either via nebulizer, tablet, oral syrup, or inhaler, but should be administered in correct technique when we're using inhaler. For that, the side effect would be tachycardia, tremor, hyperkalemia, insomnia, and nausea. The third one would be Atrovent, for which the assessment includes monitoring respiratory rate and symptom of anaphylaxis, such as angioedema, urticaria, bronchospasm, and rash should be monitored. Administration should be done as inhaler and administered in acute exacerbation via nebulizer. And its side effect includes skin flushing, dyspnea, symptom of a common cold, dizziness, sinusitis, dyspsia, back pain, UTI, tachycardia, bronchitis, and nausea. Erythromycin. For that assessment would be monitoring fever, cough, phlegm, which can give sign of improvement of infection, and its administration is usually given per oral or IV depending on severity. Side effect would include GI upset, possible QT prolongation, and antibiotic resistant with prolonged use. Ritonavir and nirmatrelvir is the other medication that can be done. For that, assessment would include monitor if it's effective to control COVID-19 symptoms, monitor for adverse reaction, hypersensitivity, and drug-to-drug interaction. It can be administered orally, antiviral combination, and side effect would include diarrhea, hypertension, myalgia, hypersensitivity, and potential drug interaction that should be closely monitored. And for my last slide, I have included all the references that I've used in this presentation. Thank you.